get started. Welcome everyone. This is the first day of the online version of the clinical cardiopulmonary physiology course. And I'm sure you all are aware of that we are running this course as a short afternoon sessions, 2 hours every day throughout the week, opposite to what we typically do every year or used to do every year, which is a 2 full day sessions in person. So we thought this 2 hours afternoon would probably work well. And we have a session every day. Today I am joined by Dr. Regan Giesinger, who from Iowa, to actually moderate this particular session with me. And we have a series of lectures planned for foundations in neonatal physiology by the experts and our very good friends from US and Europe and Canada, actually. 3 countries, three areas being represented today here in the panel. So these are very brief 20-minute lectures. So they are really crisp. And what we want to do is we don't want to stay on time for the most part. We in the very end will take a pretty long, more than half an hour for a Q&A period. So what I would ask you guys is to actually type your question and questions in the Q&A section of the chat at the end of perhaps each lecture, or as and when the questions come to you. And then I and Regan will try and address, put those questions to the speakers to the best of our ability. So I think with that said, not to waste any further time, I'll ask Regan to start introducing our speakers. The youngest one will probably go first in terms of speakers.
Yes.
So Regan, over to you.
So our first speaker is Patrick Mcnamara, Professor of Pediatrics here at University of Iowa, and he's going to talk to us about essential principles of cardiovascular physiology. Take it away, Patrick. Thank you.
Okay, can you guys hear me okay? Thanks, Regan. Thanks, Amish, for the introduction today to this, I think, probably one of the most important courses that neonatologists can attend. The title of my talk was meant to be The Principles of Physiology, but I've actually relabeled it as Hemodynamics is Physiology. And that's for a very intentional reason. And I'm going to start this talk today very much at 37,000 feet above the air, and then try to come down to ground level in terms of some of the important concepts. So these are the the goals of the session. Briefly talk about why physiology is important, what's different about the immature cardiovascular system, and what are the important governing principles as they are applicable to the neonate, both in terms of health and disease. So why do we need to, and why is it absolutely incumbent of us as neonatologists to re-embrace physiology? Well, non-physiology based care doesn't work. For too long, we have reduced the field to a very superficial approach to thinking about the cardiovascular system. And if one looks at the 3 of the following fairly common, important scenarios that we meet on a day-to-day basis, they are all full of controversy. There's really a lack of consensus regarding who to treat, when to treat, which leads to significant inconsistency. So I would summarize the contemporary challenges in care into the following. 1, we have major clinical challenges which very much relate to diagnostic and precision, and over the next 5 days, you will learn more about how, particularly with comprehensive imaging, our ability to better understand disease, populations at risk, and so forth, has improved. And as a result of this lack of diagnostic precision, oftentimes it leads to a non-judicious and equally imprecise approach to therapies. And having visited many programs across North America, across the world over the last 10 to 15 years, the one resounding theme that I hear is nobody talks about physiology. When you ask the question to faculty, why do you do that? The answer is, well, that's how I always did it. That's not acceptable. We need to move beyond that. So if we think of neonatology, and I would actually reduce our contemporary approach to very much a symptom-based approach to care, in which, based on these individual symptoms, we can provide drugs to try to fix those symptoms. But in thinking of them in isolation, we move far away from what we should be doing, which is how can we think about the problem or the disease? And if you start to think of these symptom constellations, most of these problems in the cloud may cause these symptom complexes, but without the appropriate information and the appropriate physiologic thinking, it's very difficult to provide precise care. So where do we start? Well, I think we need to start at blood pressure. I'm not going to talk very much about blood pressure, but I think it's important to recognize that what we have learned is that a blood pressure-centric approach is not associated with enhanced patient outcomes. We also know that the vast majority, almost 100% of clinical trials in neonatal hemodynamics are based on symptoms rather than population of interest. And neither of these consider the uniqueness of the myocardium. And Phil is going to go into much more detail about the distinct properties of the right and the left ventricle. So what do we know about blood pressure? What we know is that when you look at neurodevelopmental outcomes at 2 years of age, that a blood pressure-centric approach does not change neurodevelopmental outcomes. However, other indices, such as cerebral oxygenation, the adequacy of brain perfusion, perhaps may help us identify populations at risk. So our problem is that we try to simplify something that's very complex. If you think of the modulators of cerebral blood flow at all ranges of cerebral blood flow, variance in blood pressure, variance in cardiac output, variance in vascular resistance, and the autoregulatory ability of the brain are likely to influence cellular perfusion and the optimization of metabolic activity of the brain. Yet, all of our research has focused on just one element of this. We should not be surprised that we don't have an answer to the question. So back in 2004, the birth of the Hemodynamics Club, thanks to Istvan Seri, the concept that we need to move beyond blood pressure and think more physiologically was born. So why do we need to think beyond blood pressure? Well, firstly, blood pressure does not predict cardiac output. This is some work looking at both left ventricular output and SVC flow. And you can see, and you'll probably see slides like this several times over the next week. It's a non-linear association such that there are patients with high blood pressure that may be in a low cardiac output state, and patients with low blood pressure that may have adequate perfusion. You'll probably see this slide, and again, I don't make any excuses for presenting this to you. You'll see it probably several times over the next week. This is the ultimate goal of everything we do, is to optimize cellular metabolism, which depends on oxygen delivery and oxygen consumption. Delivery is dependent on hemoglobin, oxygen saturations, and the following modulators of cardiac output that we will talk briefly about today in terms of their ability to further modulate oxygen delivery. So we need to start off somewhere, and starting off, we need to think about the fetus. And there are certain things conceptually that are important to think about. Firstly, and most importantly, is that the fetal myocardium is different. It's got different development, and it's got different responsiveness, particularly it's afterload intolerant. The second and most important concepts to think about are the modulator roles of shunts. And in utero, the patent foramen ovale determines or ensures that blood which returns from the placenta and the lower part of the body enters into the right atrium and ultimately perfuses the brain. So the PFO modulates cerebral perfusion. The PDA is the ultimate modulator of blood returning from the head and neck, which basically crosses the right ventricle into the pulmonary artery and perfuses the lower part of the circulation. What do we know about the myocardium of the preterm infant? And Phil probably will talk in a little bit more detail about this. Well, we know that developmentally there are major changes that occur over time, both in terms of interstitial cardiac collagen, myocyte volume, myocyte cross-sectional area, and the numbers of myocytes that are present in the immature myocardium. such that up to 30 to 40% of the immature myocardium includes non-contractile tissue. And the sarcolemma, unlike the mature adult in which they are very nicely arranged in a synchronous manner, they're quite scattered, which leads to fundamental differences in particularly relaxant properties of the heart. The second thing that one needs to be very cognizant of is that the predominant developmental mode in play in the immature myocardium is one of proliferation. And this hyperplasia, hypertrophy cycle is incredibly important. Up until late childhood, the heart continues to mature by hyperplasia, after which point hypertrophy is the more dominant form of action. Disruption of this hyperplasia, hypertrophy cycle, I believe, is incredibly important. Certainly, we're starting to learn from adults born preterm data that particularly the left and the right ventricles are small in size, have got less cells, but more hypertrophic cells. Potentially, this lack of myocardial endowment may have major lifelong repercussions, and we're starting to learn this. What we don't know is what interferes and turns off hyperplasia and turns on hypertrophy, and when does that actually occur? And it's incumbent of us to figure that out. So from a physiologic perspective, what is different? Well, firstly, and again, predominantly due to differences in restrictive properties of the heart, unlike the adults, the Frank-Starling law, which demonstrates major augmentation in contractility and cardiac output with increasing filling pressures, but you can see that both for the fetus and the newborn, it's relatively flat. So across a normal range of atrial filling pressures, further augmentation of preload doesn't lead to further increase in contractility, except at the lower end of filling pressures. The potential exceptions to the rule are two. First, situations with extreme impairment in myocardial compliance, such as hypertrophy or pericarditis, in which you have restricted filling of the heart, may be situations in which excessive volume may be of benefit, or circulations like the Fontan circulation, which are pressure passive. The second concept, and potentially probably the most important concept in neonatal hemodynamics, is the relationship of the myocardium to afterload, which in essence is when you go into the gym and you squat or you bench press. If we focus on the graph on the left, on the x-axis is wall stress, which is a surrogate index of afterload. On the y-axis is contractility. And if you look at the adult versus the neonatal lines, you can see that the slope of the line in the newborn is much steeper, such that augmentation or increments in afterload will lead to a much more significant decrement in myocardial contractility. If you focus on the graph on the bottom, you can see, this is some data which was performed in an echo-cat study, that the RV is actually even more sensitive to afterload than the left ventricle by virtue of a steeper afterload graph. Why is afterload important? Well, the transition is all about changing loading conditions, and particularly for the left heart. Conditions such as pulmonary hypertension reflect an increase in afterload to the right ventricle. Conditions like surgical ligation of the ductus represent an increase in afterload to the left ventricle. And you will hear more about these as the week goes on. The next concept we need to talk about, and this is a concept that most neonatologists, not only do they not talk about it, they don't understand or remember that it exists. This is the force-frequency relationship, which is the relationship between heart rate and contractility. What you can see is that in a normal patient with a normal heart, as heart rate increases, contractility increases. But there's a limit, and beyond which extremes of tachycardia, and particularly if they're sustained, are more likely to lead to a diminution in contractility. Where this is most important is in situations in which you have heart dysfunction. And you may end up with a blunted force-frequency relationship. So if you choose a drug which will increase heart rate, but the positive inotropic actions of this drug are not effective, all you will achieve is tachycardia with sustained impairment in heart function, which will lead to potentially worsening of heart function, because we remember that coronary perfusion is dependent on your aortic diastolic pressure. And if you've got extremes of tachycardia, the amount of filling time is reduced, which will lead to lower coronary artery perfusion. This principle is incredibly relevant in preventing ECMO. Most of the babies that we see that come to us as ECMO referrals are extremely tachycardic with a failing right ventricle. And this concept is probably the major physiologic principle at play. This is, again, some in vitro data looking at the immature myocyte in the top versus older infants, just to emphasize the point. With increasing heart rate, you can see the cycle length decreases. In the infant, the force of contraction increases, but in the newborn, there's little augmentation in the force of contraction. The final concept is the relationship between myocardial compliance and heart function. This is influenced by both Hooke's law, as you can see here, in which the relationship between distance is dependent on the load, but also important to remember that compliance is really the relationship between volume and pressure. If you look at the graph on the top, you can see that in a heart that is either normal or very good compliance, increments in volume lead to a much lesser effect on pressure. However, in the malcompliant heart, such as this here at the bottom, the infant with the hypertrophic heart, you can see that for an increment in volume, the effect on pressure is much, much greater. The final thing I want to very briefly mention is the relationship between the ventricles, and Phil will probably go into much more details. This is some work from Anima Solo, demonstrating very nicely that both the right and the left ventricles are quite interdependent in terms of the impact to one ventricle is likely to influence the other ventricle. And this is because we must remember that the fibers of the RV and the LV are completely intertwined, and such that any major load to one side of the heart is going to impact the other. So what about application of these concepts? Well, we need to think about health and we need to think about disease. After birth, with elimination of the placenta, there's an increase in afterload to the left heart and a reduction in preload to the right heart. Improved lung compliance leads to a decrease in afterload to the right ventricle and an increase in preload to the left heart. And these are the principles that are at play in why it takes time for your oxygen saturations to improve. Lung recruitment, changes in resistance, changes in RV performance are important modulators of the adequacy of pulmonary blood flow and the time it takes your oxygen saturations to normalize. Building on this concept, it's important to recognize that RV pressure takes time to normalize. This is Abe Rudolph's sentinel piglet study, which shows that it takes up to 14 days for your RV pressures to normalize. And this is important in terms of thinking about pulmonary hypertension. The second important concept to recall, again from Abe Rudolph's CAF study, is that the relationship between PVR and PO2, again, is not completely a linear, it's actually a parabolic relationship. But important to remember that across a normal range of PO2s, boosting PO2 to a high level doesn't do anything of benefit in terms of decreasing pulmonary vascular resistance. Rather, one is probably exposing these patients to an increase in oxygen-free radicals. Again, playing on the RV and the adaptive process, this is some work from kind of Amish study that we conducted back in Toronto in the mid-2000s. Something interesting about the RV and that in the postnatal circulation, that it takes time for the RV to reach a level of adaptive response that we would say is normal. As to why that is, well, there's many possible explanations, but in patients in whom the ductus remains open, it's important to remember that the RV is potentially not just exposed to pulmonary, but also to systemic vascular resistance. This was a very intriguing observation because if one starts to think about the relevance of this, as we are getting better ways to evaluate the RV, we're starting to learn that actually impaired RV performance may be more common than we previously thought. In infants with HIE undergoing therapeutic hypothermia, it appears to be an important association, at least, with brain injury. And in the transitional period, both for preterm and term infants, RV dysfunction appears to be the most common form of dysfunction that we see. So what about the relevance to health and disease? Why is thinking about physiology important? Well, the following scenario of impairment in oxygenation and low cardiac output state, one can manage those symptoms. However, one needs to think about what are the physiologic situations that are at play. These are a series of vignettes from a cohort of from 3 babies who happened to have maternal diabetes. These were all asphyxiated infants. And what you can see is that their hearts are incredibly different. The baby on the left-hand side actually had impairment in left heart preload due to hyperinflation. You can see an empty left heart. So one needed to manipulate the mechanical ventilator. The baby in the middle, you can see that the right ventricle is not contracting. This infant needed some support for its RV and potentially prostaglandin. And the patient on the right represents an example of impaired compliance. We've seen this already. The hypertrophic heart that does not tolerate tachycardia because filling is important. The last concepts I want to mention today before moving on to our next speaker is the relationship between pressure and flow. These were emphasized by both Henry Darcy in the setting of a porous medium and George Ohm in the setting of electrical activity, such that blood flow is intimately related to resistance and pressure, such that pressure equals flow times resistance, plus potentially left atrial pressure. As vessels become vasoconstricted, there's an increase in resistance that will lead to a reduction in flow. The converse is seen in the setting of vasodilation. And this is very important if we actually think about nitric oxide. When we scan babies that receive nitric oxide and respond, many of whom go to room air, there is no immediate change in pulmonary artery pressure. They still have bidirectional PDA shunts. And that's because the effect of nitric oxide is a reduction in resistance and an improvement in flow. And the benefit that we see following nitric oxide is through this augmentation in flow. That's important. So why do we need to know about this pressure-flow relationship? Well, we're starting to learn that in many conditions, such as chronic pulmonary hypertension, the components of pressure are important to recognize. We oftentimes think of this just in terms of resistance and elevated PVR, but augmentation in flow through shunts will give an increase in pressure. Augmentation in left atrial pressure through downstream hypertension, LV diastolic dysfunction will lead to an increase in pressure through this mechanism. And this is important because each of these conditions here require a different physiologic approach to therapy. Finally, and we'll talk about this in more detail, what about shunts? Well, we assume that the PDA is a nice cylindrical vessel. In reality, it's not. These are some vignettes showing it comes in all sorts of shapes and sizes. In thinking about flow, one needs to thank Frederick Poiseuille and the Hagen-Poiseuille law. There are certain assumptions that one needs to think about. First, that flow is Newtonian, it's laminar, it's non-compressible, and it doesn't accelerate. And the components of Poiseuille's law are determined by the diameter of the vessel, which is cubed, the length of the vessel, the pressure gradient between the aorta and the pulmonary artery, and finally, the viscosity of blood. Why do we need to think about Poiseuille's law in the setting of PDA? Although we don't have a lot of strong human evidence, variance in carbon dioxide level, either through vasoconstriction or dilation, will have independent effects on pulmonary blood vessel tone and systemic tone, as will oxygen. There's some limited evidence that through augmentation in PEEP, one can increase pulmonary vascular resistance, which may also influence flow. And these concepts are important in terms of trying to further refine the amount of flow across the ductus, and we'll talk about this later. So, in summary, hemodynamics, I hope I've convinced you, is all about physiology. You can provide care, and we provide care every day, but we need to provide the best care, which requires enhanced diagnostic precision. Knowledge of the developmental properties of the immature cardiovascular system and its unique responsiveness to loading are paramount. Thank you very much.
Thank you so much, Patrick. That was very insightful. We're going to keep the questions for the end. So please, if you have any questions in mind for Patrick, just type them in the Q&A and we'll bring it to his attention in the very end so he can address all of them together as a panel. Our next topic is a lecture on normal neonatal myocardium. And it's a really important topic because a lot of what we do in cardiovascular care is actually coming from this particular concepts, which as neonatologists we really need to get a good handle on. There is no better person to talk about this than my good friend Dr. Philip Levy. Dr. Levy is a neonatologist and an assistant professor of pediatrics in Harvard Medical School, and is a prolific researcher in the field of neonatal hemodynamics and a permanent fixture in this particular course. I personally actually have learned a lot by listening to his talk. Every year I take something new and actually take it to my clinical practice. So without any further delay, Philip.
Thank you. And Amish, thank you for that introduction. I long for the days when we can be kind of back in Toronto sharing a pint. It's always great to be able to follow Patrick, to be able to kind of reinforce some of the same topics. I have no disclosures. When I personally think about cardiovascular diseases in the neonatal period, I often break it into the left heart and right heart diseases. And I think probably everybody on this phone call, on the Zoom, is very well aware of the different diseases that can affect cardiovascular physiology: sepsis, hypoxic ischemic encephalopathy, neonatal arrhythmias, diseases that affect prematurity like the ductus, chronic lung disease, and of course, some of my vested interest with congenital heart disease. But I think before you can delve into cardiovascular disease, you need to understand normal neonatal health and the development as it begins from the embryological stages, how it is different between the left and the right ventricle, both with function and structure. What are the physiological differences between a neonatal heart, a heart in a child, and that of an adult? And finally, it's important to understand how the neonatal heart responds to physiological stress, for example, hypoxemia and acidosis. And this will be our four main learning objectives today. So I want to take one step back. And again, a lot of these concepts Patrick touched upon, but it's important to understand the major components of the cardiovascular system. You have the heart, which acts as a pump. You have the vasculature, which supplies blood, or the transport vehicle for oxygenation, delivery, and consumption to both the pulmonary and systemic circulation, where the goal of the heart, the function, is to pump blood either to the right side or the left side. And it's this concept of oxygen consumption and oxygen delivery, which is really borrowed from slides put together by Patrick and Afif, who will be our fourth speaker today, where it's looking at the relationship between cardiac output, which reflects the heart, the target organ or the vasculature network, and then the blood oxygen delivery and consumption. But what's key to understand, and Patrick pointed out, it's truly a balance between preload, afterload, and contractility that helps us determine the overall function of the heart. And all of this, which I will show you over the next 15 to 20 minutes, is tied into the morphology. So understanding morphology will help us understand the function of both the right and the left ventricle. For example, when we talk about cellular homeostasis and HIE, that Regan Giesinger has become an expert in this field, we're talking about the relationship between cardiac output and cerebral autoregulation. When we look at the relationship between cellular homeostasis and pulmonary vascular disease, both Laura Thomas and Amish are experts in this field, we understand it's a relationship between right ventricular performance and the target organ of the pulmonary vasculature. So these principles will guide us as we delve into the 6 components of neonatal myocardial mechanics. First, we'll start off with a little embryology and some history. For those who have heard this talk, you know I'm a history buff, and I really love the fact that the evolution of the cardiovascular system began back with Hippocrates, who hypothesized that blood came from the liver and then turned itself magically into air, and air is what supplied the body and all of the nutrition. Now, we know from Galen physiology, which came about at the turn of the century, instead of this kind of blood to air philosophy, it was really blood seeped through invisible pores in the myocardium and went from the right side to the left side, and that is how we got blood to the systemic circulation. This way of thinking persisted for 1,500 years. not because it was right, it was actually wrong, but because it was in the dark ages. And anybody who contradicted this way of thinking ended up dying. It wasn't until William Harvey in the Renaissance period showed us that it's a closed vascular system where blood goes from the liver through the right atrium, through the right ventricle, to the lungs, and back to the left side of the heart, and then out to the body to supply that systemic circulation. So for me, it all goes back to embryology. Most neonatologists are very comfortable with airway development with these 5 stages, but it's fascinating that cardiac morphogenesis precedes airway development in that embryonic stage, and the vasculature arises from a temporal and spatially controlled process that's linked to both airway development and cardiac growth. And I'll walk you through some examples in the next few slides. For me, cardiac embryology is tied to genetic investigations. For those who are interested in congenital heart disease and trying to understand the link between, let's say, the right ventricle and pulmonary circulation, you only have to go back to embryology. The right heart and the pulmonary outflow tract arise in week 2 from the second heart field highlighted in blue, while the left ventricle and the systemic circulation arise from the first heart field. And you can see that with the folding and the twisting and the key regulators, that our understanding of acquired heart disease and congenital heart disease can all be tied back to embryology and genetic investigations. When we think about vascular development, we know by the 5th week of gestation, there is a multi-layered vascular network between the vascular system and the heart, where we have the fetal stage, airway, and vascular, where we see as we increase in the fetal stage with increasing airway anatomy, the vasculature, both arterial and the venous, will increase in both size and number over time. So when we look at just this first part, we know by the 3rd week, we have sustained contraction. By the 4th week, we have an active circulation that exists between the heart and the lungs. And by that 5th week, we have a separate right ventricle and pulmonary circulation and a separate left ventricle and systemic circulation. When we think of morphology, I think about the layers of the heart, the location, the chamber structure, and the fiber orientation. And all of this dictates the function of the heart. And that's why it's important to understand that the right side is not the same as the left side, and a neonatal heart is not the same as an adult heart. What we know from development is that in utero, in the 1st and 2nd trimesters, that right and left ventricle almost look the same. They're very spherical. The septum in the middle is flat, but by birth and 1 month of age, the right ventricle is a crescent. It's flat, it's thin, while the left ventricle remains round and thick. And you can see from the yellow highlighted septum, it goes from flat to kind of this bowing into the right ventricle. When we think about the dominance patterns, we know in utero, the right ventricle is the dominant ventricle. We've learned from work out of the Children's Hospital of Philadelphia using fetal echocardiography that cardiac output increases from about 210 at 20 weeks to close to 2,000 at 38 weeks. And that right ventricle output slowly increases over time, but is more predominant than the left ventricle output. This work has been followed up by work from Mike Seed in Toronto using MRI to show very similar results. And when we look at the macro growth, it's important to understand that at 25 weeks, and that's what we all deal with in our units every day, the heart weighs 4 grams, the size of a dime. By 40 weeks, it's 20 grams, which in our term today is the size of an N95 or the weight of an N95. And when we look at the spectrum from an adult heart all the way down to a premature heart, we know the adult heart is about 250 grams, which is about half of a soccer ball or a football. The adult male heart weighs one proper job, 290 grams. The term heart is about the weight of a Duracell, and the preterm heart is the weight of 1 British coin. When we think about layers of the heart, there's the epicardium, there's the endocardium, but I'm going to focus on the myocardium. I want to look at myocardial muscle fibers. I want to look at muscle cells and connective tissue to tie in the concepts that Patrick alluded to. So here's Patrick. When we think about our location and our orientation, I really like to use this picture from him from about 5 years ago. We see that the heart has a base, it's apex forming, it's in a specific location, but the preterm heart, it's slightly rotated, where the apex and the PMI are in a different location compared to the term, or the adult, or in this case, to Patrick's beach body. So here is a nice apical 4-chamber view of the heart, where we're able to look at the top chambers, the right atrium and left atrium, and the bottom chambers, the right ventricle and the left ventricle. And what we know is that the left ventricle is really a conical shape. It has a myocardium, it has an inflow component. It almost looks like an ice cream cone. When we look at the right ventricle, it's a complex tripartite structure. So just think about that. It's tripartite. It has an inlet component, an apical trabecular component, and an outlet component. So when we look at the kind of the cross-sectional view, or the parasternal short axis view, we can again see that the right ventricle is kind of a kidney bean shape on top, and the left ventricle is a nice symmetrical circular shape with the mitral valve in the middle. And when we take a summary of this, we know that the structure of the right ventricle is different than the left ventricle. The shape is different with crescent and triangular. The wall thickness is larger in the left ventricle. The mass is larger in the left ventricle, and the left ventricle overall is longer. Moving on to the fiber orientation, as Patrick alluded to, there are 3 distinct unique fiber patterns that wrap around the right and the left ventricle, and they're shared. What we know is that the fiber orientation is what dictates the morphology and dictates the function of the heart. Here's an example where the heart is twisting and relaxing. A lot of people know this as rotation or torsion, but what we've learned is that there are several layers. Here's an example of a top layer and the sub-epicardial layer that I mentioned. And then immediately beneath that is going to be a sub-endocardial layer. But I want to take you through this a little bit more in detail so you can understand the nuances here. Here we have a top layer, superficial oblique, sub-epicardial, wraps around both the right and the left. Beneath that in layer 1B is another superficial oblique that wraps around the back, but again, the right and the left ventricles. Finally, next you have a kind of shared longitudinal pattern, again between the right and left. And finally, you have a circumferential pattern only on the left side of the heart. So when we put it together, the right ventricle has 2 layers, where the deep longitudinal layer is the dominant layer that provides a major contribution to stroke volume and ejection fraction. But the left ventricle has 3 layers, where the deep circumferential layers is the major player and dominant layer that gives you the major contributor to ejection fraction and stroke volume. This is important when we're talking about developing measures to assess cardiac function. You can't have a measure to assess circumferential changes in the right ventricle because they don't have that layer. There's also intraventricular dependence, and this Patrick alluded to, showing that there is a shared fiber data plan. So if you have right ventricular dysfunction, you have to first rule out if there's left ventricular dysfunction because they're sharing similar fiber patterns. It's important to understand the blood supply. I only briefly mentioned this. You can have a baby who has hypoxic ischemic encephalopathy, has hypertrophic cardiomyopathy. It can actually be due to a coronary issue or a blood supply issue. So knowing the differences between the right and left ventricle blood supplies is very imperative. It's also important to understand the filling properties and where does the blood come from. For the right ventricle, the deoxygenated blood comes from the right atrium. It sends blood to the pulmonary system. The filling properties, it starts earlier and it finishes later. And this is in contrast to the left ventricle. All important topics when you're trying to determine pathology. Next, we'll look at the cellular level. What we know between a neonate and a child is simple. The neonate has disorganized myofibrils and very few mitochondria. When we look at this caricature, you can clearly see that the nuclei are larger in the neonate, the sarcoplasmic reticulum is disorganized, and what we learn in the child is you have these larger T tubules, which really act as a coupling mechanism between the sarcolemma and the sarcoplasmic reticulum to really facilitate release of calcium. You can clearly see that the number and the size increase from the preterm infant all the way to the adult. So why do we care about this? Well, we care about it with contractility properties that Patrick alluded to. In a child, we rely on the L-type channels. We bring in the white dots, the extracellular calcium into the cell, and that promotes an active release of intracellular calcium. And this will then promote contraction of the myofilament. And eventually, All of this is dependent on L-type channels and T-tubules. This picture comes from my good friend Afifa Kufash, our fourth speaker. And what we know is that in the neonate, they have less L-type channels and less T-tubules. So their ability to augment contractility and relaxation is impaired compared to a child or an adult. Overall, cellular metabolism plays important roles in cardiac development, conductive system, housekeeping function, contraction, and ultimately with an immature sarcoplasmic reticulum, we're at a disadvantage. The classic example is with neuronone. It's a phosphodiesterase 3 inhibitor. We know that in the cardiac muscle cell, if we block phosphodiesterase 3, it promotes contractility and increased stroke volume. We know within the smooth cell, if you block phosphodiesterase 3 pathway, it leads to vasodilation. But with an immature sarcoplasmic reticulum, you have impaired calcium metabolism, and this whole process with milrinone just won't work as well. There's new data in babies with hypoxic ischemic encephalopathy where milrinone has not the best effect in these children to get the changes you desire, and it's probably due to the cooling effect and also the impact on the immature sarcoplasmic reticulum. So just to summarize this, we know that there are alterations with myocytes, myofibrils, differences in connective tissue, differences in mitochondria, differences in nuclei, and differences in T-tubules between neonates and adults. So moving on to performance. Now, Patrick alluded to this, so I'll be able to go through it a little bit quicker, but you have to understand that the myocardial muscle fiber orientation dictates the contractility patterns. Morphology relates directly to function. With the right ventricle, we know that the contraction of the longitudinal fibers pull the tricuspid valve towards the apex. There's also an inward movement of the right ventricular free wall. That's called the bellows effect. And then there's traction of the RV free wall from its connection to the LV free wall at the apex. Now, the left ventricle has three different patterns you have to be aware of. There's concentric circumferential patterns. There's contraction of the longitudinal or oblique fibers. And finally, there's this rotational or torsion. We've had a lot of work come out of the Irish group and the Toronto groups, really looking at torsion patterns as it relates to infants of diabetic mothers, as well as Down syndrome babies. Patrick alluded to this, but here is the pathology behind this. Neonates and preterm infants have decreased contractile states. There's a higher collagen to protein ratio. There's also in the term lambs compared to the preterm lambs, there's less fibrosis, which overall leads to a decreased contractile state. When we talk about preload and afterload, it's important to understand according to the Frank-Starling curves, as Patrick alluded to, as you go up on your preload, you can no longer augment your stroke volume in an immature heart to the same degree that you could do in a mature heart, highlighted in red. And similarly with afterload, as you go up on your afterload, you will not be able to augment stroke volume in an immature heart the same way you could do it in a mature heart. The classic example that Patrick alluded to is with the hemodynamically significant PDA. When you have definitive closure of the PDA, all that blood that was going into the lungs is now not going back to the left atrium, so it leads to a decrease in preload. And all of that blood that was going into the lungs is now going into the systemic circulation, and the body can't handle it, so it increases afterload. Most babies are okay, but some babies cannot handle that because they have a preterm myocardial response where changes in loading conditions leads to alteration in function. And this is best understood in low cardiac output syndrome, where you'll have changes in oxygenation and ventilation, and you'll have changes in systemic hypoperfusion. So what we've learned is morphology relates to preload and afterload, which ultimately relates to contractility and overall myocardial performance. And the last two topics, which I'll finish up with, is metabolism. So we've learned that the preterm heart relies on glucose. The term heart relies on fatty acids, and the adult heart relies on beta oxygenation. What we've learned is that the preterm heart is able to tolerate acidosis and hypoxia. We've all been there in the delivery room. The preterm infant comes out, they're hypoxic, their initial gas shows acidosis, but for some reason they seem to all bounce back. Work from Shahab Nouri really highlighted this. On the x-axis, you have pH. On the y-axis in figure A, you have a measure of function. And on the y-axis in figure B, you have a measure of contractility. Irrespective of the degree of pH, all the way from 7 to 7.5, both function and contractility are preserved in the preterm infant. What we've learned from Melissa Bates and the group at Iowa is a lot about vascular tone. We've learned with percent maturation on the y-axis and the trimester on the x-axis that the parasympathetic system is fully formed after birth, but it's the sympathetic innervation that's incomplete. You have alterations in your alpha and your beta adrenergic receptors. So you have a higher vascular tone, and this will reduce the net inotropic effect of agents. So if you're giving dopamine, if you're giving epinephrine and you're not seeing the results you want in the preterm infant, it's because of the underlying neonatal cardiovascular tone. What Melissa has shown us is that it's beyond heart rate, it's beyond stroke volume, it's beyond afterload and contractility and preload. It really relates around neuroendocrine and paracrine regulatory mechanisms, where you have prematurity-induced disruption of cardiovascular control. And these factors are just important as understanding the loading conditions. So to put it all together in my last 30 seconds, we know that there are differences in cellular mechanisms over time from the embryonic stage to the adult stage. We know that there are changes in metabolism and there are changes in performance. And when we break it down and look at the preterm heart and compare it to the diseased heart, we actually see very many similarities, but we know the preterm heart is not diseased. It can recover over time. So to highlight, I've shown you that the primary role of the cardiovascular system is to achieve cellular metabolism. It's a highly coordinated process that's linked to programmed structural, functional, and genetic mechanisms. There are differences in the right and the left ventricle that depend on the cellular, metabolic, and functional demands of each ventricle. And finally, there are hemodynamic responses that are unique to the preterm heart as it relates to stress. And with that, I just want to highlight this excellent article written by my colleague, Adam Lewandowski, that really summarizes all of this work and will be a launching pad for the next 4 days of this excellent symposium and workshop. Thank you very much.
Thank you very much, Phil. And I'll just take this opportunity to introduce our next speaker, Dr. Danny Weiss of Sunnybrook Hospital in Toronto. Take it away there, Danny. He's going to talk about cardiopulmonary interactions.
Okay, Regan, thank you very much. Thanks very much to Amish and to all of the speakers. It's an honor to be involved again in this great course. So my topic is cardiopulmonary interactions in the mechanically ventilated infant. And I think what you've seen so far is some very amazing look at the in-depth physiology and how that relates to morphology. This talk is I think a little bit more practical, and we really delve into some specific case management issues, which highlight how we use cardiopulmonary interactions in day-to-day practice. I have no conflicts of interest to disclose for this presentation. And in the interest of the historical lessons we've had so far, which have been great, I want to show you that cardiopulmonary interactions have been discovered almost 300 years ago. It was by Stephen Hales, and you can see in a little pictorial here that him and his assistant attached a blood tube to the carotid artery of a horse and measured changes in the height of the blood column with inspiration and expiration. This was the first time, again, almost 300 years ago, that an interaction between breathing and heart function and cardiac output was first identified. And I'm hoping that after the next 20 minutes, you'll be able to do the following, and we'll try and integrate these principles into a couple of clinical cases. The first is to know that the impact of positive pressure ventilation on systemic venous return and thereafter pulmonary blood flow depends on right atrial pressure. That positive pressure ventilation may effectively reduce left ventricular afterload. That ventilation and lung volumes help determine pulmonary vascular resistance, which is, for most of our babies with normal anatomy, the major influence on RV afterload. And we'll have a chance to apply these principles in some common clinical scenarios, as well as I'll ask you to kindly participate in a couple of friendly polls to encourage everyone to participate in thinking about cardiopulmonary interactions. So I'd like to start off with I think a very common case scenario that a lot of people face on a fairly regular basis, and that's of a hypotensive 24-weeker. The case scenario is this 24-weeker who's now 2 hours old is one that you're taking care of and has severe hypoxemia and systemic hypotension. This baby was intubated at 2 minutes of age because of poor respiratory effort and has a saturation of 70%, both pre and post-ductally, in 100% oxygen. The current settings that you have the baby on is on high frequency oscillation with a mean airway pressure of 10, an amplitude of 20, and a frequency of 10. As any good neonatologist would, you decide to administer a dose of surfactant, and there does appear to be an initial response because the saturation increases initially to about 97% for 5 minutes, but then it decreases thereafter to 85%. So currently you have your baby on about 90% oxygen with a saturation of 90% on the right hand and 84% on the right leg. You have an umbilical arterial catheter in situ recording a blood pressure of 22/9 with a mean blood pressure of 12 millimeters of mercury, a heart rate of 170, and your arterial blood gas is shown there, 717 with a CO2 of 78, a PaO2 of 25, a bicarb of 20, and a deficit of 7. So in response to this, you decide to escalate support and you increase the mean airway pressure to 12 and the amplitude to 30, and you decrease the frequency to 9. So our first poll question is based on what should you do in this scenario given the X-ray that I'm showing here. So this is an AP of the chest and abdomen. Baby was fortuitous to get a PICC line, and you can please ignore the fact that there's no umbilical arterial catheter in this particular baby. But what would you do if you got this particular X-ray? Would you administer a second dose of surfactant? Would you increase the mean airway pressure for alveolar recruitment? Would you decrease mean airway pressure to reduce overdistension? Or would you initiate inhaled nitric oxide because this baby has presumed PPHN? And I'll give you about 30 seconds to put in your response. Okay, it looks like almost everyone decided to decrease the mean airway pressure to reduce overdistension. I think that is probably the right answer in this case, and it highlights the effect of changes in intrathoracic pressure on systemic venous return and right heart function. And I'll draw your attention to the right side of your screen, which is just a schematic of how the pressure gradient between the peripheral vein over here and the right atrium drives systemic venous return. And as you may have recalled from Patrick's talk, that flow is contributed to by the pressure gradient divided by the resistance. That's a general principle, and that certainly applies to systemic venous return. And that pressure gradient is the pressure difference between the peripheral circulation, so the peripheral vein, minus the pressure in the right atrium. And of course, divided by the venous resistance, which you can consider to be relatively constant in anatomically normal kids. And on the left is a schematic of the model of the circulation showing the various factors that impact systemic venous drainage. The key highlight here is that the right heart is within the thorax and therefore is subject to the effects of intrathoracic pressure. That intrathoracic pressure, when transmitted in high volumes to the lung, and that occurs when lung volumes increase, and the pressure in the thorax does get transmitted to the right atrium and increases right atrial pressure. That as right atrial pressure increases, the pressure gradient between the peripheral veins and the right atrium decreases, and therefore the blood flow also decreases. So the key point is that transmission of intrapulmonary pressure to the heart occurs when lung volumes increase. And this is related to lung and chest wall compliance. So as we saw in our case example, that when the pulmonary pressures, when the mean airway pressure is large, and that has resulted in an increase in lung volumes, that's when the intrapulmonary pressures are transmitted to the heart, and specifically the right heart, which increases the right atrial pressure and decreases the pressure gradient between the peripheral veins and the right atrium. And this reduces systemic venous return. Now, scenario number 2 is a slight modification of the first one. So I'd like you to consider that same infant, except the case where you administered surfactant, but without any improvement in saturation. So again, in the first scenario, the saturation had increased to 97 and then come back down to 85. In this scenario number 2, you administer surfactant, but don't see any improvement in saturation at all. So in this scenario, the baby is currently in 90% oxygen, has again saturation of 90% in the right arm and 84% in the right leg. The blood pressure is still low and the baby is mildly tachycardic. The blood gas is similar. Again, it's a mixed respiratory and metabolic acidosis. And again, in response, support is escalated. The mean airway pressure is now 14, amplitude of 25, and a frequency of 9. Now, in scenario number 2, this is baby's X-ray, different from the first X-ray. And I'll remind you that for this baby, the mean airway pressure is 14, and the systemic blood pressure is 22/11 with a mean of 13. So I'll give you a moment to consider this scenario. Which of the following would be your recommended management? Would you give a second dose of surfactant, increase the mean airway pressure for alveolar recruitment, decrease the mean airway pressure to reduce overdistension, or administer inhaled nitric oxide for presumed PPHN? Okay, a bit of a more mixed picture here, which probably reflects, certainly reflects clinical practice, and that there are certainly various options here. I think administering a second dose is certainly reasonable, depending on where you think the first dose went. But based on the X-ray, it probably appears to be a reasonably collapsed lung. And I thought that increasing the mean airway pressure for alveolar recruitment would be a reasonable first step. And what it reflects in terms of the principles of cardiopulmonary interactions is that this particular scenario is unlikely to be a problem of impairment in systemic venous return, because although the mean airway pressure in this scenario is higher than in the first scenario, it has not resulted in an increase in lung volumes. Now, a question that I've gotten several times is it a problem if the mean airway pressure is greater than the systemic blood pressure? And in this case, the mean airway pressure was 14 centimeters of water, and the mean blood pressure was 13 millimeters of mercury. This question has come from several trainees and even faculty who have asked, what happens to systemic venous return and cardiac output when mean airway pressure is increased greater than systemic blood pressure? And a couple of important points here. First is that they're in different units. Centimeters of water is not the same as millimeters of mercury. 1 centimeter of water is about 3/4 of a millimeter of mercury. But more important is the principle that the impact of mean airway pressure on hemodynamics, specifically systemic venous return, is directly through its impact on lung volumes. So you're only going to have an adverse effect on systemic venous return if a baby becomes hyperinflated due to excessive mean airway pressure. But at the same time, while systemic venous return may be affected as lung volumes increase, it's not. There's a backup plan with systemic hemodynamics that help out, and this is the venous return or cardiac output versus right atrial pressure curve. So on the y-axis again is venous return and cardiac output, and the x-axis is right atrial pressure. And this is a schematic of cardiac function curves on various levels of positive and expiratory pressure. So the curve that's labeled ZEEP or ZEEP is the cardiac function curve with 0 PEEP. And the curves labeled PEEP 10 and PEEP 20 are the cardiac function curves with 10 and 20 centimeters of water of PEEP respectively. So as you can tell, as PEEP increases, the cardiac function curve shifts to the right. Now, the curve labeled VR0 is the venous return curve when PEEP is 0. And as we might expect, as right atrial pressure increases, there is an expected decrease in systemic venous return. However, there is a modulating effect of the provision of PEEP. So in the absence of PEEP, one might expect that if right atrial pressure were to increase, that venous return would decrease going along this curve from point A to point D. However, as you can see here, there's a curve labeled VRP, which is venous return in the presence of PEEP. And in the presence of PEEP, there is a shift in mean circulatory pressure from here, MCPZ is mean circulatory pressure at 0 PEEP, whereas this is the increased mean circulatory pressure in the presence of PEEP. So instead of venous return declining from point A to point D, due to an increase in mean circulatory pressure, the venous return goes from point A to point B. And this, of course, represents a mitigation or a limitation in the reduction in systemic venous return. And that occurs because of an increase in mean circulatory pressure associated with the application of PEEP. So the take-home message here is that with increasing PEEP and lung volumes, the cardiac function curve shifts to the right and mitigates, though does not entirely prevent, the decline in systemic venous return. Now, what if you actually need to increase the PEEP? What if you're in a situation where you are not sure that you have adequate lung volumes, or you know you have adequate lung volumes, but you need it to be even greater? Well, there have been some experiments to help us decode this situation and manage it in our clinical practice. So these are Starling curves of the left and right ventricle output versus end diastolic volume at different levels of positive end expiratory pressure in adult humans with ARDS. And here they were measured by thermodilution, which is, of course, the gold standard. And as you can see, the way to interpret these Starling curves is to start up here, both on the RV side and at the LV side, where the PEEP is 0. Now, as PEEP increased, there was a linear, almost linear reduction in end diastolic volume and, of course, in cardiac output. What this experiment showed was that if at the time of where these patients were experiencing a PEEP of 20 and had a reduction in both end diastolic volume as well as cardiac output, that augmentation of preload with a bolus of 20 cc's per kg of normal saline improved both the end diastolic volume and cardiac output back to its baseline. So this is represented by a PEEP of 20 plus volume expansion. So this is an indicator that if you're using higher mean airway pressures and it is impacting end diastolic volume and cardiac output, you can certainly at least temporarily return the circulation back to its pre-PEEP preload by administering exogenous crystalloid. Now, what about the much often talked about debate of high frequency versus conventional ventilation? This is data from preterm baboons with RDS and a comparison of the effects of mean airway pressure on left ventricular output and effective systemic blood flow from baboons who were treated with conventional mechanical ventilation on the left, as well as high frequency ventilation on the right. As you can see, there really is no difference in left ventricular output or effective systemic blood flow for these baboons who are treated with HFO versus conventional ventilation. The key detail, of course, here is that the mean airway pressure was the same for these patients on HFO versus conventional. And more data to that effect. This is data looking at cerebral perfusion and mean airway pressure in a pig model. And both high frequency and conventional mechanical ventilation resulted in decreased cerebral perfusion as mean airway pressure increased. However, it affected both of them equally for the same mean airway pressure. So the key take-home point here is that conventional and high-frequency ventilation will have a similar hemodynamic effect when using the same mean airway pressure. And there's an asterisk there for a reason which I'll address in a moment. And of course, if you, when increased PEEP is needed, cardiac output may be restored with administration of saline. Now, the asterisk that I inserted there, it conveys the fact that for most institutions, high-frequency ventilation is a rescue mode of ventilation. And when initiating it as a rescue mode, generally the mean airway pressure is increased beyond that of what was administered on conventional ventilation. So if that is the case, you can expect some potential reduction in systemic venous return if that increase in mean airway pressure results in increase in lung volumes and increase in right atrial pressure. Okay, let's move on to our third case scenario, which reflects the question of what is the effect of lung volumes on right ventricular afterload. So I'd like you to consider a 39-week term male who has severe hypoxic respiratory failure after birth, which is complicated by chorioamnionitis and looks like meconium aspiration. This baby improves with invasive ventilation and sedation, but still has persistent high oxygen requirements. And echocardiography reveals suprasystemic pulmonary artery pressures and severe biventricular dysfunction. So in general, this is the next poll question: how might targeting a certain lung volume be helpful in babies who have PPHN, or acute pulmonary hypertension at birth? So which of the following is correct? Increased mean airway pressure can be used to expand lung volumes to total lung capacity, which will improve VQ matching? Or is it that targeting low lung volumes at residual volume to avoid overdistension, volutrauma, and barotrauma is the way to go? Or finally, should you target lung volume at functional residual capacity, which is where PVR is minimized? Okay, great. Most people chose to target lung volumes at functional residual capacity. And I would say in general, in clinical practice, that's probably going to be the right answer when deciding how much invasive ventilatory pressure to administer. There's a physiological basis for this, certainly for babies who have an increase in pulmonary vascular resistance. This is the U-shaped curve of pulmonary vascular resistance and shows how pulmonary vascular resistance changes with lung volumes. Now, the total resistance of the pulmonary circulation depends on the balance and the vascular tone of its two compartments, the alveolar vessels and the extraalveolar or parenchymal vessels. Now, overdistension above FRC compresses the alveolar vessels, who have no perivascular support and thereby increasing their resistance, while underinflation below FRC results in two things that increase PVR. You have, most importantly, extraalveolar vessels become increasingly tortuous at residual volume, and this increases their resistance. You also have terminal airway collapse of low lung volumes, and this leads to alveolar hypoxia. And at an oxygen tension that's low, generally below 60 millimeters of mercury, you also have resultant hypoxic pulmonary vasoconstriction. Overall, though, the net pulmonary vascular resistance is this U-shaped curve with the nadir located at functional residual capacity. So overall, if you have a baby with APH or PPHN, the general approach should be to target their lung volume at functional residual capacity in order to minimize their pulmonary vascular resistance. Well, we just spoke about right ventricular afterload. Let's talk about the effect of mechanical ventilation on left ventricular afterload. So for that same baby, this is our 39-week baby who has severe HRF and likely meconium aspiration. And this is one echo clip of showing severe LV dysfunction. And I don't know if that RV function is normal, but certainly maybe a little bit better than the LV, but it has suprasystemic pulmonary artery pressure. What is the effect of mechanical ventilation on the LV? Is it helpful? Is it harmful? Well, in general, it's going to be helpful. That PEEP may be helpful for LV dysfunction by reducing the transmural stress. And as you may recall from Patrick's talk, that afterload is proportional or is related to pressure times the LV radius divided by the LV wall thickness. And the key here is the pressure. And the major principle here is that that the heart is not functioning in isolation. It's within a milieu of the thorax and is affected and can be affected by adjacent pressures from the lung in terms of the pleural pressure, as well as potentially from the pericardium and the pericardial pressure. Now, this concept sometimes seems a little abstract if it's something that hasn't come across before. So the very simple arithmetic exercise to take you through, just to highlight the potential positive impact of positive pressure ventilation in reducing net LV afterload. And we'll look at two scenarios. The first is a scenario of negative pressure ventilation or spontaneous ventilation, and also we'll look at positive pressure ventilation. The principle here, of course, is that for blood to be ejected from the left ventricle to the aorta, the pressure in the LV at the end of isovolumic contraction needs to be greater than or equal to the pressure in the aorta. And the concept here is that the pressure in the LV is contributed to by not just the LV transmural gradient, which is the pressure that the LV itself has to generate, but also by adjacent structures and the adjacent pressures. Those pressures are the pericardial pressure as well as the pleural pressure. So overall, for a hypothetical aortic pressure of 30, which is obviously a little bit low, but perhaps we have a very preterm baby, that the sum, the LV pressure needs to be equal to or greater than 30. For our example, for someone who's spontaneously ventilating, their net pleural pressure is negative, certainly, and becomes more negative with inspiration. And in this scenario, in order for the sum of these pressures to meet or surpass this threshold of 30, the LV must generate a pressure of 33 millimeters of mercury. On the other hand, for a baby or anyone who's receiving positive pressure ventilation, assuming that the aortic pressure is unchanged, although I'll discuss in a moment why that's not always the case, but in babies receiving positive pressure ventilation, the pleural pressure is going to be universally positive. And I've arbitrarily put in a number here of 8 centimeters of water. In the setting of a positive pleural pressure and assuming the pericardial pressure has remained unchanged, our little arithmetic exercise here tells us that the LV has to generate a substantially less pressure, only 20 millimeters of mercury, in order to for the sum of the LV pressure to meet the aortic pressure, and for blood to be ejected from the LV and generate a stroke volume. So that is illustrated here in this diagram from Shahab Nouri's chapter. And this is a person who is spontaneously ventilating with an aortic pressure of 20. And if the pleural pressure is negative 20, then the LV transmural gradient must be equal to or greater than 120 in order for the sum of these pressures to supersede the aortic pressure. On the other hand, for a person receiving positive pressure support, if the pleural pressure is positive, then the LV has to generate a far lower transmural gradient in order to meet aortic pressure and generate a stroke volume. So the principle here overall is that positive pressure support causes an effective reduction in left ventricular afterload, and that's due to a reduction in the LV transmural gradient. So that's the hemodynamic effect. Of course, anyone with severe LV dysfunction, often you might choose to intubate and ventilate, or at least provide non-invasive positive pressure support, not only to reduce LV afterload, but also to maintain alveolar patency and mitigate the effects of pulmonary edema from left atrial hypertension. So overall, putting this all together, how can one optimize hemodynamics during mechanical ventilation? Well, first is to minimize any impairment in systemic venous return. So as clinicians, we should anticipate and avoid pulmonary overdistension, and that's through things like putting the settings on volume guarantee mode if we're administering surfactant, being aware of any rapid changes in pulmonary compliance. The second is to consider augmenting the gradient of systemic venous drainage using volume expansion, gravity, or the effective vasopressors. Second, we should aim to minimize any increases in pulmonary vascular resistance associated with the administration of positive pressure ventilation. That generally involves targeting functional residual capacity. And finally, is to consider optimizing support for the left ventricle. And many of the problems that we face in neonatal practice when it relates to cardiac dysfunction are actually due to impacts and changes of loading condition rather than problems with intrinsic myocardial contractility. So something like administering positive pressure support for a failing left ventricle makes a lot of physiological sense. So the take-home points are that there are several hemodynamic effects of administering positive pressure support. First is that that overdistension, that increase in lung volumes, affects venous return. It results in impairment in venous return as well as poor cardiac output. Though in cases where you need that PEEP, it can be overcome at least temporarily with volume administration. Second, that you can improve a dysfunctional LV by reducing transmural stress through administration of positive pressure support. And of course, you can optimal lung volumes, optimizing them at FRC minimizes pulmonary vascular resistance. As you can remember, the U-shaped curve of PVR against lung volumes. And finally, keep in mind that there's no difference between high frequency or conventional ventilation with respect to the effects on hemodynamics, and that is for the same mean airway pressure. And an optimal mean airway pressure and lung volume is really critical to successful ventilation, oxygenation, and hemodynamic support. And I thank everyone for their participation and the opportunity to speak today. And thank you, my colleagues at the NHRC and my colleagues at Sunnybrook here in Toronto.
Thank you so much, Annie. That was an excellent one. You explained quite complicated concepts using nice schematic diagrams. So hopefully everybody was able to follow, and we hope can have some more discussions in the end about it. Our next lecture today is about assessment of tissue oxygenation, and it is coming from another partner in crime, my crime, is Dr. Afif Al-Kafash, who's a neonatologist and clinical professor in Rodenda Hospital in Dublin. And again, along with the other panelists here at UGC, is one of the leading researchers in neonatal hemodynamics across the world, and a leader in the field in Europe. So Afif, over to you. Thanks a lot for coming, man.
Thank you, Amish, and thank you for the lovely introduction. And I'm delighted to be here. So I'm gonna delve right into it. So all the speakers to date have talked about the importance of neonatal hemodynamics and the physiology. And I'm going to complement those talks by talking about the assessment of tissue oxygenation. You've seen this, or a version of this figure over the last 3 or 4 slides, but you have to kind of agree that this is the nicest one yet. So as you know, our ultimate aim in our series of lectures and in what we're trying to achieve is maintain adequate cellular metabolism. So, and in order to do that, you need to have an adequate cardiac output and an adequate blood oxygen content. And I want you to just take a mental note of those 2 terms that I've just used, because we're going to delve into talking about them a little bit in greater detail. So I'm not going to talk about cardiac output because that's been covered adequately in the previous talks. What I'm interested in is blood oxygen content, because it's all well and good pumping blood around into the cells, but the blood that you're pumping must have an adequate level of oxygen in order to maintain adequate cellular metabolism. And you have to take into account as well cerebral autoregulation. So what does blood oxygen content depend on? Well, it depends on oxygen transfer, and it also depends on the level of hemoglobin present in the blood. And I'm going to talk about a few definitions that people may sometimes use interchangeably, but they are sort of distinct things. When we refer to oxygen content, we actually speak about the the amount of oxygen bound to hemoglobin plus the amount of oxygen dissolved in arterial blood. Now, the majority of oxygen is actually found bound to hemoglobin. And there's a very small amount of oxygen that's dissolved in arterial blood that is not really usable by tissues. And this is the formula that defines that, indicating, sorry, I'm just gonna get my pointer out. You can see here from the formula that blood oxygen content, or arterial oxygen content, is mainly determined by the amount of hemoglobin present in the bloodstream. So the more saturated the hemoglobin, the higher the oxygen content in the blood. And you could see here that the factor of the dissolved oxygen is minute. So you could always kind of correlate blood oxygen content with the amount of saturated oxygen in the blood. That's why arterial oxygen saturations are a useful parameter, because they give you a very good indication of the overall oxygen content in the arterial vessels. What about oxygen delivery? Here's where I want you to pay attention. Oxygen delivery is the rate at which oxygen is transported from the lungs to the microcirculation. And that is dependent on blood oxygen content, which is dependent on the amount of hemoglobin present in our bloodstream, multiplied by cardiac output. So in order to have adequate delivery of oxygen to our microcirculation, we need an adequate cardiac output, but also an adequate blood oxygen content. I think oftentimes in the world of hemodynamics, we may have an overemphasis on cardiac output and not really pay close attention to blood oxygen content. We have these arbitrary cutoffs for transfusing infants. Transfuse if the hemoglobin is less than 12, or 120 in a ventilated infant, if it's less than 10 in an infant on CPAP, and if it's less than 8 in an infant in room air. That really does not take into account lots of nuances that may be present in each individual patient. So you often have a ventilated infant that is running a hemoglobin of 12 or 12.1 that may actually need more hemoglobin in order to improve blood oxygen content. And one case in point, for example, is an infant with pulmonary hypertension. What about oxygen consumption? Now, oxygen consumption is the rate at which oxygen is removed from the blood for use by the tissues. So it's almost a surrogate marker of metabolic demand or metabolic rate. And it is dependent on the cardiac output and also the difference. It's calculated by looking at the cardiac output and the difference between the arterial oxygen saturations and the venous oxygen saturations. Oxygen extraction, on the other hand, kind of describes the relationship between oxygen delivery and oxygen consumption. And it's most commonly expressed as an oxygen extraction ratio, which is the proportion of arterial oxygen that is removed from blood as it passes through the microcirculation. So what are the relationships between these definitions that we've spoken about? So let's quickly talk about the relationship between oxygen consumption and oxygen delivery and the extraction ratio. At rest in a healthy individual, oxygen consumption remains constant over a wide range of oxygen delivery because changes in oxygen delivery are usually balanced by reciprocal changes in oxygen extraction. What does that mean? It means that if your cardiac output falls slightly, then your oxygen extraction is going to increase to make up for that fall in cardiac output, as long as it happens within a certain physiological range. There are things that can offset that relationship. So the blue line represents the normal state where oxygen consumption is constant over a wide range of oxygen delivery, up to a certain threshold below which oxygen consumption will fall because you can't increase oxygen extraction beyond a certain physiological point. In cases of sepsis, for example, or in preterm infants who are stressed, that relationship increases. So you need a higher amount of oxygen delivery to maintain adequate oxygen consumption. And preterm infants are usually always in this pathological state where you need to ensure that oxygen delivery meets a certain threshold. Otherwise, you may run into trouble and you may impair adequate cellular metabolism. The other thing to remember is the oxyhemoglobin dissociation curve. When there is a left shift means that there is an increased oxygen affinity and reduced oxygen delivery to tissues. And preterm infants, by definition, are in this state because of their high level of fetal hemoglobin soon after birth. Their hemoglobin tends to hold on to oxygen, doesn't release it easily into the tissues, and as a result, you need a higher amount of oxygen delivery to compensate for that reduced dissociation. So, how do we measure it? Well, near-infrared spectroscopy has been an amazing kind of breakthrough over the last 10 to 15 years. And what NIRS is, it's a tissue oximeter. So what a tissue oximeter does is that it measures oxygen in tissues with the use of infrared spectroscopy. I'm not going to go into the physics of it, but what it does is that it basically represents oxygen saturation in the actual tissue that you're measuring it from. Not arterial oxygen saturations within the blood vessels, but the tissue oxygen saturations. And really, that becomes really about 70% venous, about 20% capillary, and about 5% arterial. So really, you could use it as a marker of almost the venous saturation. They usually refer to it as mixed saturation. We can also measure oxygen extraction from this by applying the formula you see here. If you know the pulse oximeter or the arterial oxygen saturations of the infant, and you have a near oximeter on the brain, for example, you can actually measure cerebral oxygen extraction by applying this formula that you can see here. So just to reiterate about the differences between the two methods, a tissue oximeter is dependent on volume and flow in all of the blood vessels, so arteries, capillaries, and veins, whilst a pulse oximeter uses artery pulsations to identify and isolate signals from arterial blood. So the pulse oximeter that we use around the baby's finger or foot gives you arterial saturations, whereas tissue oximeter gives you mixed saturations of veins, capillaries, and arteries. And really, hemoglobin oxygen is measured predominantly in the venous blood, so giving you readings between 60 to 80%, whereas pulse oximetry gives you hemoglobin oxygen saturations in arterial blood with readings of 90 to 95%. Because you're looking at tissue oxygenation, this is actually influenced by perfusion, i.e. oxygen delivery, and metabolic demand, so oxygen consumption. So you could sometimes use it as a surrogate marker of tissue perfusion if you make the assumption that metabolic demand remains constant. So for example, if you have a drop in the tissue oximeter, it usually indicates a drop in perfusion to that area within the body, making an assumption that metabolic demand has remained stable. So we usually use near-infrared spectroscopy to assess cerebral oxygen saturations and gives you a composite measure of saturations across the artery, capillary, and venous beds. And it usually reflects the balance between oxygen delivery and cerebral metabolic rate. And in preterm infants, it is assumed, although that is not true in a lot of cases, that the cerebral metabolic rate remains constant and is unlikely to vary much, and therefore a change in the regional tissue oxygen saturations reflects a change in the oxygen delivery, i.e. cardiac output. And what influences this? It is the arterial saturations, cerebral blood flow, and hemoglobin concentration. So we've done a recent study led by one of my excellent fellows, Ashleen Smith, looking at the impact of adjusting some components of these formulas on cerebral and somatic tissue oxygen perfusion in premature infants. What we did was we included infants that have a low hemoglobin that are otherwise stable and requiring a non-urgent red cell transfusion. We divided the babies into those with a hemodynamically significant duct versus those without a hemodynamically significant duct. And we wanted to look at the relationship between, between giving a blood transfusion and the resultant hemodynamic effects measured by echo and NIRS in the presence and absence of a PDA. So we had 10 infants who had an open duct and 20 infants who had a closed duct, and they all had met the threshold for an elective packed red blood cell transfusion past the first 10 days of age. We excluded any infant that was hemodynamically unstable, was on inotropes, or requiring emergency treatment for acute blood loss to try and eliminate the confounding effect those issues may have on cerebral saturations. And their outcomes were no different between the two groups, but that is not the focus of the talk. One thing we noted in the entire cohort is that pulmonary vascular resistance drops following a red cell transfusion. That becomes evident about 24 hours after a red cell transfusion. So this is measured by surrogate markers of pulmonary vascular resistance, including the ratio between pulmonary artery acceleration time and right ventricular ejection time. A higher number indicates a lower pulmonary vascular resistance. And we also looked at the LV eccentricity index, which is a marker of the septal bowing into the LV. A lower number indicates a less bowing into the LV, therefore less pulmonary vascular resistance. So you can see here that a blood transfusion does actually lead to a drop in pulmonary vascular resistance, possibly by increasing oxygen delivery to pulmonary vessels. Now, this is the interesting piece here. These are echocardiography measurements of surrogate markers to blood flow in the brain, measured by brachiocephalic artery velocity time index and the celiac artery velocity time index, used as a surrogate marker of blood flow to the gut. You could see here that in the preductal vessel, there doesn't seem to be a big difference, or there is no big difference in blood flow to the brain between infants with and without a PDA. Those with the PDA are indicated in red, while those without a PDA are indicated in blue. However, if you look at the postductal vessel, the celiac artery, you could see that the baseline flow before giving a blood transfusion was lower in the babies with an open duct compared to those with a closed duct, and it remained lower throughout the study period. Now, this is the cardiac output component of the blood oxygen content. So what happens to the cerebral tissue perfusions once you give a blood transfusion? You could see here that cerebral oxygen saturation significantly rises by 24 hours from baseline in both groups, with no real differences seen between the two groups. And because you improved oxygen delivery to the blood vessels, the tissue oxygen extraction falls. You don't need to extract as much oxygen because you've improved oxygen delivery. So you could see that cerebral fractional tissue oxygen extraction falls in both groups, regardless of the presence or absence of a duct. However, when you look at the somatic blood vessels or the somatic microcirculation, you could see that the blood transfusion only benefits or only improves saturation in those without a duct. And it lowers oxygen and extraction only in those without a duct. Those with a duct where blood flow is compromised, improving blood oxygen content does not improve oxygen delivery overall, because cardiac output or blood flow to that specific tissue in the presence of a duct remains compromised. So here's a clear example of only solving half the piece in trying to improve gut circulation. There's no point in pumping the infant full of hemoglobin to improve oxygen delivery if blood flow to a particular area of that infant's microcirculation is compromised because of left to right shunting. So this work has gleaned new insights into the impact of PRBC transfusion on PVR. I didn't show you RV function, but that also improved as well following a blood transfusion, and also cerebral and somatic oxygenation in the presence and absence of a duct. And this demonstrates the ongoing impacts ductal patency has on gut oxygenation. It'll hopefully add another piece to the puzzle of the relationship between PDA and necrotizing enterocolitis, for example. So what happens if we begin to use NIRS clinically? If we begin to act on a drop in cerebral oxygen saturations or a drop in blood oxygen content? Is it feasible? Is it something that you could introduce into clinical practice, and does it improve outcome? The Safe Boost trial, the phase 2, was published a few years ago in 2015 in the BMJ. And the aim of this kind of phase 2 pilot study, if you like, was to determine whether it was possible to stabilize cerebral oxygenation, meaning that if you notice a drop in cerebral oxygenations, can you implement a clinical protocol that is aimed to improve this the cerebral circulation. And this was done in a multi-center setting. 166 infants were randomized to cerebral NIRS with treatment guidelines compared to standard therapy. What they noticed is that they were able to successfully reduce the burden of hypoxia and hyperoxia in the intervention group compared to the control group. What they also noticed, interestingly, is that they managed to drop the rate of severe IVH from 23% in the control group to 13% in the NIRS group. And mortality was also nearly halved from 26% in the control group to 14% in the NIRS group. However, none of the study was not powered to show these clinical outcomes, and as a result, none of these values or differences were statistically significant. You could see that the baseline demographics between the intervention and control groups were very well matched. And this was the protocol. It was sort of left to the clinician to try and figure out, why is the cerebral saturations low? Do I need to look at the cardiovascular status? Is that an issue of oxygen transport, or is there a problem with the respiratory status? And, you know, these guidelines were suggestions, and it sort of prompted the clinician to take a closer look at the infant and add another layer beyond the cardiovascular status alone, to try and think of oxygen transport as well as the respiratory status of the infant. And this is a graph demonstrating how those in the NEOS group had much lower percentage hours of hypoxia compared to the controls. And as I said, they saw a reduction in severe IVH and mortality that was not statistically significant. And this prompted then the Safe Boost 3, which is an ongoing trial running across 70 sites. The aim is to recruit about 1,600 infants, and there's around 1,300 infants recruited so far, and hopefully recruitment will end over the next couple of months. And the results of this trial, like I await them in interest, and we're a center as well as Professor Jean Dempsey in Cork as well. So there's 4 centers recruiting in Ireland, in addition to many centers across North America, Australia, and Europe. So to conclude, it's important to recognize that oxygen delivery should be an integral part of your thinking process in order thinking process that is geared toward maintaining adequate cellular metabolism in preterm infants. And we need to begin integrating the assessment of blood oxygen content, oxygen consumption and extraction in our thinking when we try and stabilize an infant from a hemodynamic point of view. And the use of NIRS may prove vital in the future of hemodynamic monitoring in preterm infants. Thank you very much.
Thank you so much, Afif. That's great. Right. So does anybody in the attendees have any questions? Can you please post it on the Q&A chat box? Well, Danny has a question. Danny, who do you want to ask?
My question is for Afif. Afif, I hope you don't mind me asking you a question, but it relates to the fantastic data you presented about packed red cell transfusion and hemodynamics. There were studies in I believe in the late 70s, looking at the effect of transfusion on pulmonary vascular resistance in children with VSDs, and they're based on a lot of the Poiseuille equation, that an increase in blood viscosity resulted in an increase in PVR and a decrease in shunting. I'm curious if you can offer an explanation as to why PVR decreased in your cohort, as opposed to some of the data from babies with I guess they were older babies, they were infants with VSDs where PVR increased as blood viscosity increased.
Yeah, that's a great question. I was hoping nobody was going to ask it, but of course, Danny, you've read all the literature. Yes, so obviously when we were writing the discussion for this paper, we had to delve into all the literature, and really there is about half the paper show a reduction in PVR following a blood transfusion. The other half show an increase in PVR following a blood transfusion. And I think it depends on your baseline hematocrit and how viscous your blood is prior to your transfusion. In our scenario, we're bringing their hematocrit up to a normal physiological level rather than a super physiological level. And as a result, the net effect, I think, is a lowering of PVR by improving oxygenation. I think the situation you're alluding to is when maybe the blood viscosity is increased significantly, and that offsets or mitigates the benefit of improved oxygenation. So I think it's a fine balance that you see, and I think that explains the contrasting studies, because I think a lot of those patients, they're varying patient populations, they begin from a very different baseline, whereas with us, they were all, I suppose, low on hemoglobin. All their hematocrits were relatively about 0.3 and lower. So, and we were bringing them up to only 0.35. So none of them became polycythemic as such. So I think that explains the difference.
Can I ask Danny a question? As soon as he asked a question, I'm going to throw one back at him. Danny, excellent talk, as always. one thing we don't talk very much about is the impact of mechanical ventilation on pulmonary vein flow. Have you come across anything in terms of what it does directly to forward flow into the left atrium, or back pressure effects causing interstitial edema and the lungs looking worse and then driving people to increase the ventilator further? Have you seen anything either in animals or kind of even adult data to the effect?
I haven't. Thanks, Patrick. It's a great. I've looked for it. I haven't found it. Specific, pulmonary venous, the effects on pulmonary venous return. I think if we were to conceptualize it, that the impact would be one of several factors. First is the impact, just as right atrial pressure is prone to change as lung volumes increase. It's the same pressure changes might occur in the left atrium, and so that may affect or impair systemic venous return in an overdistended lung. So I think it's in fact, as you alluded to, more complicated on the left side because of if you have pulmonary overdistension, then you also have alveolar overdistension and impairment in pulmonary blood flow. So trying to tease out whether it's a lung volume problem, a true pulmonary blood flow problem, or a left atrial pressure problem, I think there are a few factors to tease out. But again, as you've alluded to, I haven't found any specific pulmonary venous literature.
All right. There are a couple of questions posted by the attendees, so I'll put those first before we ask our questions. Abhijit has asked a couple of questions. I'm going to merge them together. What is the effect of CDH on myocardial development, both left and right ventricle, and its clinical implication, as both pulmonary vasculature and myocardial development are interdependent? And are there any prognostic markers in terms of hemodynamic parameters to prognosticate the cases? And are there any hemodynamic parameters we can look for in the antenatal scans? If I may, Abhijit, there is going to be a talk from Neil Patel in the coming days, I think day after tomorrow. He's going to talk about CDH and pulmonary hypertension. So perhaps a part of that question could also come there. But in terms of development point of view, perhaps this question should go to Phil. Phil, is there any in the literature the interdependence of pulmonary vascular bed and myocardial development?
Yeah, it's a great question. So I think it ties in to what I presented with the morphology can dictate the function. Neil will present some of the pathophysiology, and we know that with CDH, there's primary and secondary impacts on the pulmonary vasculature. But I think what we've learned, at least with left ventricle and right ventricular function or dysfunction, there is both a morphological kind of sense with the impact of like the compressed left ventricle, which can in turn affect preload, which can in turn have an effect on diastolic dysfunction according to kind of the Frank Starling laws. And what we've learned really is that this is kind of a transient pathophysiology. It often goes away over time once you have the repair, as opposed to the right ventricle dysfunction, where you can have changes in right ventricular morphology, which could be primary or secondary. You can have in utero impact on the right ventricle function, but it's mostly the postnatal impact with the adverse impact on the pulmonary vasculature. That's kind of the way I think about it. In terms of, are there any antenatal predictive markers? I don't know of any antenatal predictive markers in terms of myocardial function that people have looked prenatally and tracked it to the postnatal world. But there is ongoing work that Neil's been a part of that's used strain imaging. So really looking at the deformation or the change in the shape, both on the left and the right side. But a lot of attention has been paid towards tissue Doppler imaging, diastolic dysfunction, and then of course tying it back to pulmonary vascular biology and pulmonary vascular disease and hypertension, where I think Neil will expand on it tomorrow or in the upcoming days, but really just tie it back to the morphology when you're thinking about his explanations.
And if I may add, there have been a few attempts and looking at the PAT and RVET ratios in the branch pulmonary arteries, particularly the left pulmonary artery, measured in the fetus antenatally. It was published in obstetric and gynecology journals, which seem to correlate the severity of oxygenation difficulties after birth in CDH infants. But that really hasn't translated into a routine clinical care per se as such, because I'm assuming because of technical challenges. But apart from that, I'm also not aware of any antenatal markers which can tell you the severity. Having said that, the lung ratio using MRI, it's such a sensitive marker of mortality risk that I don't think any additional things were adding anything more on top of that. That's just my understanding.
Amish, can I just make a comment?
Yeah.
I think we're only at our infancy in understanding LV versus RV development. I would just remind everyone that most of the research that's been conducted suggesting that a large portion of these babies have LV hypoplasia is based on retrospective reviews of echoes that are performed anywhere up until 48 hours of life. And we all know that the profoundly ill infant with pulmonary hypertension due to ventricular interdependence may have a very small looking left ventricle. And all I would comment is in the last 3 years from, and I'd be curious to know from you, Amish, from Sinai, in looking at a lot of these babies who we scan in the first hour or so after birth, we don't see a lot of very small LVs. And these are a pre-treated patient population. We see a lot of right heart disease. And obviously over time, if they don't do well, their LV can look small in the most critically ill RV patients. So I think there's I still think we're at a hypothesis generating stage of the CDH disease, as opposed to we know the answer. I don't think we know the answer yet.
Yeah.
So I'm just going to ask one of the other audience questions, which is also addressed to Danny, I think. And if you could just clarify one more time why increasing PEEP doesn't actually increase LV afterload in the same way as it does for the RV. And to just try to kind of clarify how it doesn't affect the aortic flow that way.
Thanks very much. Thanks for the question. My apologies, I actually had asterisked the aortic pressure in that little arithmetic exercise, and I apologize, I actually did not explain it then. So I think the comment is well founded, because when you apply positive end-expiratory pressure and that results in an increase in lung volume, you will see an increase in aortic pressure. So that is certainly the case. The blood pressure that you measure will increase. However, LV afterload is, while in principle in anatomically normal hearts, normal vascular systems, systemic blood pressure is the dominant contributor to LV afterload. But the key amongst babies who are receiving mechanical ventilatory support is that the transmural gradient, the pressure that the LV myocardium has to generate in order for the intraventricular pressure to meet and then exceed aortic pressure, is contributed to not only by the pressure generated by the myocardial contraction, but also by the pressures applied to the heart externally from the pericardial pressure and the pleural pressure. So although increase in pleural pressure will result in an increase in aortic pressure, that is offset the other way by the contribution of the pleural pressure to reducing the LV transmural gradient. And overall, it's to a net benefit of the left ventricle, such that the LV transmural gradient is overall reduced. And that is why the net effect on afterload is lower, even though the systemic blood pressure is marginally increased.
Thank you. And can I just ask you to also comment on what if there is a difference in the application of PEEP or pressure to the cardiovascular system in the setting of well aerated versus whited out lungs, and how that may be modulated, if at all?
Do you mean, Regan, for which particular any particular hemodynamic parameter, like RV, LV?
RV in particular.
Yeah, thanks. So I think the one thing that I think is relevant for clinical practice, and I use conceptually day to day, is the U-shaped curve of the relationship between pulmonary vascular resistance and lung volumes. And mean airway pressure or positive pressure ventilation is helpful, whether you increase it or decrease it as a goal to get the lung volume to functional residual capacity. So if you are already high up on the curve and you're over distended, then you actually should reduce your mean airway pressure to reduce the lung volume so that you are at FRC. Conversely, if you are in an atelectatic state and under-recruited, I mean, not only are you likely having hypoxic respiratory failure, but this is an obvious thing that, again, most of us do on a day-to-day basis. An under-recruited lung, certainly any baby where you think you have pulmonary hypertension, the first thing you're going to do is ventilate and recruit to FRC. And once you're at FRC, there are some babies, I'm certain all of us, on this discussion today, there are babies where, they're on 100% oxygen on a map of 10, and in the back of your mind, you're thinking, maybe this baby will eventually need a pulmonary vasodilator, but then as soon as you optimize lung volumes, perhaps give them some sedation, you bring their lung volume to FRC, their PVR comes down and they actually oxygenate and ventilate just fine. And you don't have to go down any augmentatory treatments such as, inhaled pulmonary vasodilators. So the principle there again is just targeting FRC at your lung volume and using and applying your mean airway pressure accordingly.
So I'm gonna just ask one more question of my own to Patrick, who's escaped without having any questions asked of him for quite a long time in this session. Can you tell us why we're able to use output calculations for cardiac output to specifically quantify left ventricular output or right ventricular output, but we're not actually able to do that, or we don't do that for the PDA?
I think it's based on the laws and assumption. Okay, so even with our normal calculations, there are certain assumptions that we must use and apply for, at least for left and right ventricular outputs. We have got some measure of concordance with indwelling cath-based measurements using the Fick principle. For PDA, one can't translate that concept based on the fact that the ductus, so the images I showed you were what we see in real life, which are that the PDA comes in all sorts of shapes and sizes. The flow across it is not necessarily kind of Newtonian. It's not circular in cross section. It varies in its diameter from the pulmonary end to the aortic end. So that test of circularity, you can't rely on that. And also you don't have a length that is consistent. So based on that, again, it would be perfect if you could come up with a clear volumetric assessment that the ductus was cylindrical and so forth. We can't do that, which basically means that we have to rely on surrogate indices, kind of using echo as indirect measures of presumed augmentation of volume. But even in that, it's not a perfect science, because there are some of these measures are dynamic. So the Doppler-based assessments of aortic flow, end organ flow are very much dependent on dynamic transductal pressure gradient and resistance of the organ, whereas other things like left heart volume, for example, are not dynamic. The left heart doesn't get big and small every hour. It tends to be progressive based on sustained shunting. So we do the best we can based on these surrogate indices. Does that answer your question?
Yeah, thanks.
There are a couple more comments from the attendees. One is more of a request. Can you use case examples to show choice of inotropic support online on a hemodynamically unstable preterms? I think that probably will be addressed by Regan. She's going to do a talk on approach to hypotensive infant actually tomorrow. So Regan, if you haven't done yet, can you please talk about the choice of inotropic support tomorrow? The second question is there a more precise method of determining FRC than visual speculation of the chest X-ray? Who wants to take that? Danny, you want to take that?
I'm hoping someone here can answer that question, because I
If there is,
certainly.
can someone let me know where to get it? Then I'd be very happy to have it.
So I can just throw a little bit of a sort of comment in there that there actually been study looking at the in preterms on HFO using the accuracy of X-ray and the type of X-ray analysis that you can do to actual measure lung volume when they were I think they used xenon gas to actually label it to measure lung volume, and they found that no matter which quantitative part of X-ray you try, rib counting, perimetry measurements and this, that, and other, nothing worked. Nothing actually correlated with the lung volume measured in any good way that you can clinically use. So yeah, X-rays are qualitative, as you rightly said, just a visual speculation. And I'm not sure how you are in your system, but in our system here, rib counting used to be a popular sport in an ICU, and I certainly discourage that quite a lot. But there isn't one. I think FiO2 is, that's why the FiO2 responds to your pressure, and it still remains the gold standard way of knowing where your FRC is. As they often say, find the closing pressure, which means when you are increasing your MAP, your oxygenation improves, and when you're reducing at a particular time point, it starts worsening. That's your closing pressure you're trying to find. That's what still is the clinical thing for me, at least. I don't know, anybody has any more comments on that?
Yeah, one comment from the chat and then one from the Q&A. A couple of suggestions were a combination of X-ray and lung ultrasound, or the pressure volume loops on the ventilator, which both can be helpful. There is one study that's a similar population to what Amish mentioned, looking at the measurement of right ventricular output within baby in a serial basis with increasing PEEP, that showed as PEEP increases, right ventricular output goes down. It doesn't tell you very much about comparing baby to baby, but if you have serial measurements and that's all you've changed, then you can potentially use right ventricular output as some additional information in that situation.
I think there's another request from Olayenka about a session discussing various scenarios of hemodynamic significant PD and management approaches. This is a constant sticky point. I think that's a talk that Patrick would be covering on November 18th when we talk about PDA physiology. I'm not entirely sure in the short session of 20 minutes how much different scenarios of management approaches can be discussed, but we'll try and talk about it as much as possible. So that will be on November 18th. Patrick, that's your request to you.
No problem. I'll do my best. But I think the last comment with the lung is that, it's very difficult to truly appraise what we're interested in, which is actually functional lung volume. We know from MR studies that what you see on X-ray is just the anterior lung lobes. These lungs are collapsed posteriorly. Unless you put the babies on a skewer and rotate them constantly, it's very difficult to get to what we want to. But anyway, interesting questions.
I can just add, I have one other question for either Phil or Patrick or both. Both of you mentioned that there are developmental differences in the myocardium, one of which is related to calcium handling. I'm just wondering if either of you or both could comment on a potential advantage of using a medication like levosimendan in preterm babies or in newborns as an alternative inotrope.
I can go first because I know we're running out of time here. I have no experience with using it because it's not available in North America. So it would be nice. It seems to make sense, but I think there still is a lack of literature. I'm not aware of too many studies using it. I know in South America, some of our colleagues there are using it as a dobutamine type of agent, but it seems to make biological sense. But I have no experience.
They're using them in Europe also, but we don't have access to it. Philip had to leave. I'm not sure whether he's able to answer the question. He's still logged in. Philip, are you there?
I think he's gone.
Yeah,
We
he
have to run off to Amish to another conference. Maybe we should wrap it up.
We sort of finished the time as well, and there is one more comment in here. This will be the last question, perhaps. This should have been for Afif, but I think Afif had to leave also. What's preventing the routine use of nares in NICU so far as compared to pulse oximetry? What's preventing it apart from resources and money? What do people
think good validation science, that something that you do based on that leads to something happening better in patient outcomes. Reality is we actually haven't even done that though with regular oximetry. It just happened at a time when there wasn't a lot of scientific investment in these things. So no other good reason apart from that.
Yeah, I mean, it's essentially knowing the thresholds of action. Yeah. Because the range is quite variable, right? So what we really need is a reasonably large, in my view at least, is a reasonably large study to try and identify thresholds. And oftentimes when you talk about NEARS in a new unit, majority of existing staff will ask that question, what do I do? And unless we have the answer about it, it becomes a little bit challenging to convince. And also it is a reasonably, costly affair for the administrators to convince them you need data. But this aspect will be covered tomorrow, I think. Is it tomorrow? It is, or on Thursday, is it? No, tomorrow.
Tomorrow, I think it's tomorrow.
Tomorrow. I think we're talking about cerebral hemodynamics and autoregulation and precision in cardiovascular monitoring. So I think that's where a lot of these things might also come about, and this will be worthy discussion about what to do next. Okay, I think we're going to close the session after this. I think Laura has an announcement to make prior to everybody goes. This is the link that she's created for getting feedback from all the attendees. So as many people as can, or the people who are still here, can you please click on the link or use this QR code and fill in your evaluation for the day, and we can compile them and then look at it later. So on that note, thank you very much for all the speakers, and thanks Regan, and thank you Laura for putting it all together. And finally, thank you to all the attendees. Have a good day, guys.
Thanks. Bye.